Cool. Perfect. Oh, well, I don't know about the rest of you, but when I was in grade school and high school, I guess felt like I was a nerd. I was like a Big Bang Theory. So it's nice to know I now have that title of officially being named a nerd, which is awesome. And I'll wear that badge with honor, which is great. I really think that's cool. So yeah, so thank you all for inviting me and for coming. And if there's anybody, joining us remotely, I really appreciate this. It's been a stimulating day so far for me. And I was really pleased to be able to get this invitation because I think the space that you're all talking about is just so important. And your speaker that will be here this afternoon can really shed some additional really important light on this topic. But I want to tell you that I have some perspectives, and that the perspectives of where we are with this space is evolving very rapidly. And so I think we need to keep our eye on this ball and be ready to kind of respond. And I have some comments at the end in terms of how I think we can do that as a profession to stay very relevant in this space. So let's see, just one conflict of interest that won't affect me at all, but I'm on the scientific advisory board for a company. So on to this. Obesity is complex. It seems like it's a very simple thing when you think about it. And a lot of times we look at this from a model that looks a little bit like what I have on here, where you have these lifestyle factors, two of which are obviously eating behavior, energy intake, and I at least label this as physical activity. And we, as a profession, we kind of focus a lot on the moderate to vigorous, so I put that up there. And that if we could modify these two behaviors in a way that puts these in balance or creates a negative balance, that's going to help us with our body weight regulation. And we all understand also that when these things come out of balance and kind of create a positive energy balance, that's going to cause weight gain or adiposity to occur. So you look at this and you go, okay, that's pretty easy to understand. So all we need to do is eat differently, change our intake, be more active, and we are going to be fine. Without getting into detail, and this is by no means comprehensive, it's a lot more complex than just modifying one or the other side or both sides of the energy balance equation. And that these things are complex in that when you affect one thing, there's always a downstream effect on something else that either was or was not expected. And those things will then impact other things. And then when you impact those things, for example, in this case, I don't know if there it is. When you get all the way out here, right, you start to modify body weight or body composition, and the next thing you know, those dotted lines are feeding back and potentially impacting the things that you were trying to modify to begin with. And so this is an interactive, dynamic system that regulates body weight. It's not a static factor of body weight. You go back 20, 30, 40 years, it was a little bit more considered, well, just change the way people eat. Or all we need to do is get people to exercise. And when you got people to exercise, and we've done some of these studies, you realize some people lose weight, some people gain weight. Some people don't have any body weight change at all. Because you know why? It was affecting other systems. It was affecting eating behavior for either intentionally or not. So it's a dynamic process. And I think that as we start to think about how do we prevent obesity, how do we prevent additional weight gain, and how do we treat the condition of obesity, we have to understand the dynamics of this. And in addition to this, I think it's really important that we understand sitting on top of all of this are also genetic components, environmental components, and also as we start to think about the treatment of obesity, that there are also medical treatments targeting the treatment of obesity. Some of them are targeting other health conditions that may be affecting the condition of obesity. So it's a very dynamic thing that you just can't say, well, we're just going to hone in on one particular thing. The other thing that I want to make very clear to you is obesity is a condition, and it's a dynamic condition. It's not just one thing. It's dynamic, and I hope I can share with you on the next slide. But As we think about obesity treatment considerations, just to put a couple of things out there before I kind of get into the nuts and bolts, just some perspectives. You know, if you read the literature and you listen to popular media and you pay attention, there's a lot of concern about the use of the body mass index as a definition for obesity. And some individuals have argued that, well, what we really need to be thinking about is waist circumference as maybe a better measure. And I have a lot of opinions about this, but I think that one of the things that's come out in the American Medical Association papers on this, and there's also an international group at the WHO and others that are working pretty diligently on this, is at the end of the day, the BMI and the waist circumference are simply initial clinical tools to suggest that maybe you have to consider other factors. But those things should never be used in isolation. They need to be used in combination with many other clinical measures to understand the impact of what's going on with this individual. The other thing is that there is always variability in these relationships. And you know, I'll be meeting with a colleague of mine tomorrow in South Carolina, Bob Ross, who's a huge advocate of saying it's really about the waist circumference. And yes, the waist circumference is a very predictive factor in terms of cardiometabolic disease, but it's not a correlation of one, right? Just like the BMI is not a correlation of one. And I think that what's gotten us in trouble with the use of BMI or even waist circumference is we're trying to come up with a definitive point that when you cross that line, you have a problem, and anything under that line, you don't. You get over a 30 BMI, you have a problem. But if you're at 29.9, it's a continuum. And for some people, having a 30 BMI may not be associated with cardiometabolic disease or other diseases. For other individuals, it might be. So we have to be very careful about using these things in complete isolation. The other thing I think that's critically important is that even when we start, the argument is, well, let's just start looking at body composition. That really was what we should do. There's a lot of error in measurement of body composition. And I think that there's two things that I'll highlight here in my talk today that I'll hit now and then I'll hit it again later, is when you think about body composition, most times in clinical settings and most times in research settings, you're really measuring lean body mass, or some people may term it fat-free mass. But you're measuring lean body mass. Lean body mass is not just muscle. When we measure body composition, even with DEXA, for those of you who use DEXA, you're not measuring muscle. You're measuring the lean component of body composition. It includes muscle, organ tissues, all the other things that make up lean tissue. So when we look at changes in body composition, we have to be very careful about saying what's happening to the muscle versus what's happening to the lean tissue and not overstep that. And that's going to be an important concept I'm going to bring up here in a few minutes. The other thing is that when we look at body composition, I think that we can't just stay focused on the quantity of the composition of the body, how much of it you have. We have to also look at the quality of what you have. So I'll give you an example of that. If you take a person potentially with a BMI of, let's just go to the extreme, 40. Pretty high BMI, and they have body fatness of, let's just call it 40%. On that person, they have a lot of lean tissue and they have a lot of muscle tissue. Now let's take the person who weighs 150 pounds. Let's make it a male who has a body composition percent body fat of 7%, BMI 22. They have far less muscle. They have far less lean tissue than that person with that BMI of 40. But the difference is that the quality of what they have is better than the quality of what the other person has. Because if it was all about the volume, that person with all that muscle and all that lean tissue theoretically should be better off than the person who's leaner, but they're not. And it's because it comes down to, in my opinion, not just volume, but quality of what you have. And that's going to be a really important factor for us to be considering. And it is a limitation of how we think about body composition currently in the space of obesity. The last thing I want to highlight for you before I kind of get into some weight loss is not the only way we treat obesity. You're scratching your head going, what are you talking about? Obesity is a complex condition that is manifested in excess weight and adiposity, but it's also manifested in high inflammation, potential other cardiometabolic risk factors, glucose intolerance, insulin resistance, all these factors. And an argument that I have is weight loss solely will not completely reverse all those problems that we see with obesity. And that's going to be a big reason that we want physical activity in the appropriate dose, mode, and type and intensity in the fold to actually help the physiology improve in ways that weight loss will not. And an example of that, let me just give you a quick example of that. Publishing along the way with bariatric surgery. We took patients with type 2 diabetes who underwent bariatric surgery, and they lost, gastric bypass, lost a ton of weight. And we followed them for now over 5 years. And we looked at diabetes partial and full remission. And early on, you would expect if the weight was driving that physiology solely, once they lost 30 kilograms, no one would have diabetes and everyone would be in full remission. That was not the case. And over 5 years, as they maintained their weight loss, the number of people who remained in full or partial remission started to digress backwards. So it wasn't just maintaining now this lower weight. There's something else driving some of these factors beyond weight. And so to comprehensively treat a patient with obesity, yes, we focus on weight. Yes, we focus on adiposity, but we need to focus on all the other things that this person's experienced that are manifesting themselves as this condition, broad condition of obesity and obesity-related conditions. So we shouldn't just focus on weight loss. We should focus on improvement in holistic health and well-being of a patient with obesity. And that's a different approach than always trying to get more weight loss. More weight loss is good, but if it doesn't fix all the problems, then we need to focus on other things in addition to the weight that we're dealing with. So that's my perspective, and that's kind of where we're going with some of the work that we've been doing and are continuing to do. So as we think about that, should the focus as we think about interventions being on maximizing the weight loss? These are just hypothetical questions. Should our focus be on maximizing weight loss? Should they be on achieving a clinically meaningful weight loss? By that, a lot of folks say a clinically meaningful weight loss is somewhere between 5 and 10%. These new weight loss meds, as I'll show you, are achieving far more than that. But should our focus always be on achieving more weight loss, or should it be on achieving a weight loss that's going to give us a clinically meaningful improvement in a lot of factors that then is sustainable? That's been a big challenge in the space, the sustainability of weight loss. Or should it be on achieving a clinically meaningful and sustainable weight loss that also results in a physiological adaptation that will enhance health? And I think that last one is what we want. Clinically meaningful, sustainable weight loss. I'm not sure why it's advancing. Clinically meaningful and sustainable weight loss that improves health, but also is then coupled with something that's going to alter the physiology. It's going to have a greater improvement in holistic health and well-being. The other factor I want to bring into play, which I won't talk a lot about other than to make this quick comment, and that is one of the limitations the association between BMI, waist circumference, or even body composition with health is that most of those are cross-sectional looks at the data. I look at this and go, okay, if this person with a BMI of 38 doesn't have hypertension, hyperlipidemia, diabetes, insulin resistance, or anything. But they may have only had excess body weight at a BMI of 38. What about the person who's had excess body weight and adiposity at a BMI of 38 for 40 years? That may be the duration of the excess weight and adiposity may be a critical variable we need to take into play when looking at these associations between weight, BMI, adiposity, and so on. It's the exposure. And I also will argue to you that we need to think beyond cardiometabolic. If you take a person with a BMI of 40 who person may be rare, but no insulin resistance, no glucose intolerance, no hypertension, no hyperlipidemia, and they carry that excess weight for 30 or 40 years. They may have clean vessels. They also may need a hip replacement and a knee replacement at some point in time. So we have to think broadly in terms of health, as opposed to it's just about cardiometabolic. It's not just about cardiometabolic. It's about a lot of things, and we need to understand this. So physical activity is a thing, I think, that can add to the improvements in physiology beyond weight loss that improves health. So this is just a study this was like a meta-analysis, was published a number of years ago, probably 5 years ago or so, where this was Dr. Blair and Durstein and others, and you take a look at the first snapshot of this, and you say, okay, well, these are people compared to normal weight individuals, individuals with obesity seem to have a higher risk of mortality. Would argue then, right, that the obesity is a big driver, which I would agree. Obesity is a big driver of these things. But then you dig deeper into this, and just to kind of quickly go ahead, what you tend to start to see is when you start to take a look at individuals, and you have different individuals here who are fit and unfit. When you put fitness into the equation, even patients with overweight or obesity have protection if they're more cardiovascularly fit from a mortality perspective. So there is protection there. Not full protection, but there is protection there. And this has led, at the time, Dr. Blair to term this idea of fitness and fatness. That you can have excess weight and adiposity, but if you can at least become more physically fit, you can counter some of that. And I think that, yes, you can counter it, but I also think that you actually are affecting it differently than if you're affecting weight. And I think that this is some of the work that needs to be done. And I'll show you some slides here that I think you can differentially affect the outcomes based upon how you're losing the weight. So what are our obesity treatment options at this point in time? We base diet, physical activity, eating behavior. We have pharmacotherapy, which I'll spend a fair amount of time talking about, and the talk I know this afternoon, we'll talk about this as well. And then metabolic and bariatric surgery, gastric bypass and sleeve, and so on and so forth. And I won't spend much time on that. That's a discussion for another day. But within the space of pharmacotherapy, these GLP-1s, I mean, we're going to refer to them in different ways, but GLP-1s, Nushi-based therapies, incretin-based therapies, I mean, the names have evolved, have become very, very popular, but they're most medications that are the more popular ones that are showing all the effects on the market right now. And one of the things that I'm a little bit concerned about, and I spoke at the ACSM Health and Fitness Summit in February on this topic, was that at least in the health fitness space, the exercise people, not you, but the exercise people have had and I'm hearing things where the individuals are saying, and we're hearing it from clients who are being put on these patients who are being put on these medications. When I'm going to the gym and I have a personal trainer, and that personal trainer is telling me, I don't need these medications. If I would just do the exercise that they tell me to do, I wouldn't need that medication. Influencer in the health fitness space was on the Today Show like a month or so ago, and basically got up and said, you know what? I don't understand what's going on here. I don't know why people need these medications. All we need to do is get everybody to exercise more. And I think that we're sending the wrong message by saying that. We should advocate for exercise. We should advocate for physical activity, but understand that there's a place for pharmacotherapy. And how do we fit into that space as opposed to saying it's that or it's this? And my example is, we would not blink an eye if a person walked into a physician and they had a blood pressure of 180 over 110, and that person was put on a hypertensive medication or two. We would not say, you don't need that medication. We just need you to exercise more. We wouldn't do that, right? Why are we doing that with obesity, right? There is a place for medical treatment that is coupled with lifestyle. So let me give you an example. This is Calvin Kipton. Calvin was tragically killed in an automobile accident in later January, early February of this year. However, in October of this past year, 2023, he set the world record on the clock in Chicago and for the marathon at 2 hours and 35 minutes. 2 hours and 35 minutes. Or 2 hours and 35 seconds. Okay. So let me ask all of you, who of you here in the audience, there'll always be somebody who will say yes, but who in the audience feels that if you could train the way Calvin trained, could run a 2 hour and 35 second marathon? How many of you feel that if you trained like he did and had the environment that he was in, the sports nutritionists, the trainers, all the things that this professional athlete had, could run a 2 hour and 35 second marathon? Why not? Well, you have the behavior, you're doing the training, right? You're doing it. You have the environment. You have all the support around you that you possibly could need. If you have those things, why can't you run a 2 hour and 35 second marathon? Because underneath all of that is a biology, a physiology, and a genetic component that helps to drive how well you respond to those environments and that training that you've done, right? But there are other factors that come into play. The one that wins the gold medal. There's other factors that come into play. And we know that from sport. We know that. Performance. So let's just take out the word training and just put behavior in there. If we think about this, these are also the causes and contributors to the condition of obesity. And when we think about obesity treatment medications that are currently on the market and are continuing to be developed and are evolving quickly, they're trying to address the biology and physiology that is undermining this body weight regulation. And by doing that, it's also having some effect then on the behavior. Primarily, it's having the current meds are primarily having an effect on eating behavior, satiety, hunger signaling, and so on, right? And so I like to think about these medications not as a replacement. And in fact, if you read the inserts of the packaging, it says that the medications are supposed to be used as an adjunct to lifestyle. Lifestyle is not supposed to be used as an adjunct to the therapies. First line is still lifestyle and the medications are added, right? But I like to think about these things as evening the playing field on a physiological, biological, potentially genetic basis to give lifestyle and environment a shot at helping to regulate the condition of obesity. And if we think about it from that perspective, as opposed to it's one or the other, it changes the way we think about obesity. You know, it's kind of like Lee Kaplan, a colleague of ours who's now at Dartmouth and was in Boston for a long time, says it's kind of like when you have a person who their biology is working against them. It's like trying to push a life preserver down in the water. You ever tried to do that? Push a life preserver down in the water, and the resistance that it always is trying to push you back up? That's what the biology is trying to do. Not in every person the same way, but the pharmacotherapies help to even the playing field. So if we could give you a medication that could even the playing field biologically and physiologically and so on, you could run a 2 hour and 35 second marathon if you did enough training and you were in the right environment. The same thing is true of obesity. We're trying to even the playing field. So how do we fit into that evening of the playing field, and where does it fit? So just really quick, and I'm sure you'll get more of this afternoon. For a long time, we've had these obesity medications, anti-obesity medications is sometimes how they're termed. They were first generation medications. I'm not going to get into them. They had modest effectiveness. Some of them came and went on a lot of them came and went on the market. Some of them are still around, but modest effectiveness. Then in the mid-2000s, we started having what we'll call second-generation medications. That medication had this base called liraglutide, which was one of the first effective GLP-1 based medications. And then not that many years ago, we started to get these third-generation medications that have been approved for obesity treatment. Those have been semaglutide or semaglutide, depending on how you want to say it, and tirzepatide, more commonly known as other. These are the formal names of those things. And tirzepatide was approved for obesity treatment back in late fall of 2023, so not that many months ago. It's already on the endangered list for not being able to get access to it. So these are flying off the shelf. But just so you're aware of these things, some of these are single acting, and I'm not going to get into this. Some of them are dual acting, and now we even have a third, like triple acting medication that's finishing phase 2 and now entering phase 3. It's not approved for weight loss, but they're moving forward with varying kind of mixes and matches of these medications, and it's advancing very, very, very rapidly. So just to kind of give you a highlight of how effective these treatments are, when you take a look at semaglutide, and this is just one of the studies, I'm not going to point them all out because I'm sure our speaker this afternoon will probably talk about this a little more. When you look at semaglutide versus a placebo control, you basically see about a 15, 16, 17% weight loss, which is about 10, 11, 12 percentage points higher than what you get with the placebo control. So it's a very effective medication. And this was over, I think, a course of a year in this study. When you compare the current generation semaglutide to the earlier version, liraglutide, you can see that liraglutide got you about 6, maybe 7, maybe 8% weight loss, and semaglutide is giving us, 15, 16, 17%. You end up with still a single-acting medication, but it's better than the original single-acting medications in its formulations and things. So it's better. So that's why it's become so popular. You're getting a big weight loss with these things. We then advanced to the more current medication, which is tirzepatide, also known as Zepbound. Semaglutide, by the way, it's under the names of Ozempic, Ozempic, but that's the diabetes form of it, and Wegovy is the obesity treatment. Zepbound is the obesity treatment of tirzepatide, and we're seeing about 20% weight loss. So it's even doing better, and this is a dual-acting medication. And the retatrutide, I always stumble over that. This is now in phase 3 testing, but we're getting 24% weight loss in these. So and this is a triple-acting medication. So these medications are becoming very, very effective. But how does this stack up against what we've seen before? Well, if you take a look at lifestyle intervention programs, places where you've changed diet, you've changed physical activity, you're getting somewhere between 5 to 10% on average. The early generations of medications were actually not even doing that well. But you can see that these more current medications are doing much better in terms of weight loss. And just to put that against bariatric surgery, they're still falling a little short of bariatric surgery, but you can see how quickly they're ramping up to getting to these massive amounts of weight loss that are really having a big effect across the board on kidney function, heart disease. You start to name all the systems of the body, and they're all being benefited from this. But the one thing that's also really important for us to look at, and I know it might be a little bit hard to see, but these are data from the Diabetes Prevention Program, one of the most effective lifestyle programs. The Look Ahead program, again, very effective lifestyle program, and then the different medications. And the different colors are individuals who lost more than 5% of their weight, more than 10% of their weight, more than 15, and more than 20. And what you can see with the medications is far greater numbers of people are losing at least 5%, which is clinically meaningful weight loss, and far greater numbers of individuals are losing at higher levels. And I saw some recent data from the retatrutide trials that show virtually 100% of the people on those medications are losing at least 5%. So these medications can be very, very effective. And so far, the safety data is very, very positive in terms of, you have some things, but nothing that's of any kind of major concern when handled appropriately. The big thing, though, that I think is critically important, not the only big thing, a big thing that's important is when you look at the studies, and I just kind of didn't make the slide up, I just kind of made my own slide to show it. When you look at the studies that have had people on one of these medications and then have removed the medication and giving half the group a placebo or half of the group stays on the medication. So this idea that you can do something for obesity treatment kind of in a temporary way as opposed to a chronic way is probably not a good idea. And the analogy to that would be, it's like having someone change their diet, change their physical activity, exercise more, and after they get through 6 months, they stop doing that and expect all the benefits to remain. That's not going to happen. It's going to start to so when you stop doing something, it's going to revert back. And so we really need to think about how we continue these treatments long-term and make them available for people. And there's long-term surveillance data ongoing. But as we think about the medications, and this is where I think the physical activity and exercise come in, we know that they're effective for weight loss. We know that they're effective for type 2 diabetes. We now know that they're effective for reducing cardiovascular events and many of the cardiometabolic risk factors. We know that the limited body composition data that's out there, that it's reducing adiposity by body composition measures. The one concern that's arising, and I don't want to say it's hidden in the literature, but not all the studies have done body composition, not all of them have done it well, and not all of them have reported in a way that's easy to understand what's going on. So you kind of dig and go to the back of the envelope and do some calculations, which we've done in a couple of papers that we've looked at. But there's this potential loss of lean mass of 25 to 40%, depending on the medication. We're seeing it in their tirzepatide studies, 25-ish% loss of lean mass, and in the semaglutide studies, mid-30s to possibly as high as 40%. Our studies, but in the literature, it's not very clear. So you have to kind of figure it out. But it's clearly more than what you're seeing in a lifestyle program. And even in a lifestyle program where it's modest dietary restriction with physical activity, we still see upwards of 15% loss of lean mass measured by DEXA. So, and that makes sense. They're calorie restricted. You're going to lose some of this lean tissue. What we don't know, and none of the studies have reported on it, and I'm not aware of many studies that are even measuring it, we don't know how much of that lean mass is muscle. And we cannot make the assumption that it's all muscle because it's not been measured. We don't know that answer. We need studies to do that, and I'm proud to tell you that we've now initiated a study that's directly measuring muscle mass. And we're very excited about that, and we're coupling it with exercise to see what's happening in response. So we won't contribute to that, but these are the kind of studies that we need to have done. So before we start saying everybody's losing all muscle and everybody should just do resistance exercise, let's be careful about that because the literature does not support that right now. So what are these implications then for obesity treatment? So we'll go back to these 3 options of obesity treatment. And one of the things I want to point out to you before I talk specifically about some of the exercise stuff that we have is this is a shared decision-making thing. What treatment a patient gets is partially up to the patient and partially and that's going to be a dynamic process. It's not everybody gets the same. But when we think about this, lifestyle is still at the foundation of all of this. We still need it to be a part of it. And that foundation includes behavior modification, behavior change, behavioral counseling, nutritional counseling, nutrition modification, and physical activity. All 3 of those are important. And so you all that are in the nutrition and exercise physiology department are in prime position to work collaboratively to work on all those components together as opposed to one or the other. They're all important. But what's also important is that even when a person is put on pharmacotherapy, these lifestyle factors are critically important. Even when somebody gets metabolic bariatric surgery, maybe pharmacotherapy is important. Lifestyle is critically important. And guess what? Even when you're doing lifestyle, maybe there's an opportunity or a thought about maybe pharmacotherapy is required, maybe bariatric surgery is required. These all interact in terms of trying to figure out what's the best treatment plan. And that's what's collective, collaborative thinking behind the patient and the provider. And it's a dynamic process that can always evolve. So without getting more into this, I would point you to this paper that we published late last year, where it really highlights how the broader scope of lifestyle fits into these pharmacotherapy agents. And it does a really nice job of summarizing, at least at the time, what the effect of these medications have been, as well as what we know and don't know about the lifestyle components that are in here. And this was published in Clinical Obesity, and I think this is readily available if you scan that barcode. So where does physical activity fit? Going back to this, where's it fit? Well, again, lean mass is not muscle, volume is not quality. So let me tell you where, these are massive weight losses, 20, 25% weight loss. So the best that we can do is to say, when you're under very severe caloric restriction, which technically is what this is, you're cutting way back. What do we know about exercise under those conditions? So we did studies many, many years ago where we were doing very low calorie liquid diets, 500, 800 calories a day, pretty extreme. But we put, but it was, it's like what I'll call OptiFast at the time. It wasn't OptiFast, but something like that, if you want to put it in perspective. And we put people on these very low energy diets, but then we coupled that in 3 of the groups with either endurance exercise training, resistance exercise training, or the combination. The endurance exercise training ramped people up to about 75% of heart rate max, and it ramped them up to 4 days a week, 70 minutes a day. That's a lot. We also had people do resistance training, 8 different exercises, 3 sets, about 8 repetitions per, and they ramped up to 80% of 1 RM. So it was a big stimulus either way you went. So what did we find in that study under those severe caloric restrictions? Well, what we found is that the exercise didn't help with weight loss. The diet was driving all of it. And my impression is that with these new medications, we're going to see something very similar. The medications are driving that eating response, and it's driving the absolute vast majority of the weight change that we're going to observe. And that any exercise we do is going to be modest if we add anything. It's going to be very modest. We see that even with bariatric surgery, right? The exercise doesn't really add more weight loss. But it's not really the whole story, and we all know that that's not the whole story. So the first thing that you would ask is, well, what happened to their body composition, right? So when we looked at their body composition with the best techniques we had at that time, change in fat mass was equal across those conditions. They all lost fat mass, adipose tissue, and they all lost the same amount. What about the lean tissue? If that exercise was doing anything, we should have seen some preservation of that lean tissue beyond what we saw with the diet alone. And they all lost the same amount of lean tissue as well. Because when you get to a certain level of caloric restriction, the exercise is going to have a hard time building volume of muscle and volume of lean, because the energy you're taking in is simply there for life-sustaining purposes, not building purposes. And even if the vast majority of that intake coming in was protein, you still need that for energy as opposed to muscle building, right? So you have to think about the context of this. So this idea that, well, if people are losing lean mass on these medications and they're losing it under these big weight losses, all we need to do is give them resistance training and they're going to build muscle mass. I'm going to have a hard time believing that they're going to build muscle mass, okay? Because what we've known prior to that doesn't exist. But the popular media will lead you to believe this is what you need to do. The uneducated exercise trainer will lead you to believe this is all you need, right? That's not what all you need. So lean mass, though, is not muscle mass. Volume is not quality. So what else did we learn in these severe calorie restricted studies? Well, of course, we measured other things. We measured strength, and we created a strength index based upon a couple exercises we did, and then we normalized it to either body weight, body lean mass, body composition, whatever. But what we found in this study, and so this is not weight lifted, this is an index that we created. The individuals who did some form of resistance training got stronger. Their lean mass went down, but they got stronger. The people who did cardiorespiratory fitness in the presence of lean mass going down got more cardiovascularly fit. Those who didn't do that training didn't have that occur. And in a subsample of people, we did muscle biopsies. And when we did that, even in the presence of the loss of lean tissue, we saw that the quality of the muscle in the vastus lateralis improved, even though there was less muscle on the body, because we improved the quality of the tissue, not the volume of the tissue. And our current body composition techniques that we use in most research studies and definitely in clinical practice will not detect that. However, if I added a strength measure to that, what I'm doing in clinical practice, I might find that the people are getting stronger if they're exercising, or they might be getting weaker if they're not, right? So we have to think about this differently than it's just a number. It's about something more than just a volume number. And we summarize this in a paper we published in Obesity, this thought in Obesity last fall. It was a perspective paper, and this should be available to you. I think it's publicly available. It was a 1,500-word perspective. And it gets at this idea that we got to move beyond what we think we need to be at. And I'll show you this slide right here, but I'll blow it up for you in just a second. It's just our theoretical model of how it all works. So let's go to energy restriction. And this could be energy restriction due to pharmacotherapy, okay? And when we do that, we know that weight goes down, adiposity goes down, visceral adiposity goes down, total adiposity goes, we know that. We can measure that. We also know that those factors, those health factors that are associated, that I'll call adiposity-related chronic conditions or risk factors, will improve as we reduce body weight and reduce adiposity. We know that. And when we do that, we're improving the person's health. However, when we lose weight through calorie restriction, whether it be pharmacotherapy-induced, just diet-induced, or bariatric surgery-induced, we know that there's a reduction in lean mass. Some of that is just simply compensatory. You have less body weight, you don't need as much lean, and so on and so forth. But we then think about physical activity. And oh, by the way, this here, we don't know how detrimental this is to health. It may not be detrimental at all. It may be seriously detrimental. If it's causing a person to become frail and so on, it's going to be a real big problem. In some people, it may not be a big problem at all. It's going to vary. But in physical activity, and these are just some activities, I'll have a comment about that in just a couple of minutes. But what we know is that also can reduce adiposity and weight to different degrees. But we also know that if anything, it might without calorie restriction help to build some muscle mass. With calorie restriction, at best, we might be able to curtail the loss of lean mass and muscle mass, but it's going to do better typically in normal calorie restriction without the severe calorie restriction and helping the muscle mass a bit. And if we can do that, we're going to reduce what I'll call sarcopenic-related chronic conditions, which is also going to improve health and well-being, holistic health and well-being. However, there's also the muscle quality factor that comes in that I mentioned before. And that muscle quality, in my mind, might actually be more important than what we're seeing with muscle volume or lean tissue volume. And by doing that, we're having an extra effect on this. And some of you in the audience know way more about muscle physiology and have forgotten more about muscle physiology than I will ever understand. But I know that if a person loses weight, and even if they lose lean tissue, if they're getting stronger and their fitness is going up, that's a good thing. That can't be harmful to them. Well, it's less harmful to them, right? But then there's this other factor. There are benefits of physical activity that you get that have nothing to do with your weight. Absolutely nothing to do with your weight. And you're not going to get those benefits unless you're physically active. And so by having individuals lose weight without activity as a component, we are shortchanging them on their health and well-being and holistic health and well-being. And that's our angle, folks, when it comes to how we fit into the medical treatment of obesity. We can help the medical treatment, but we can do things for health that weight loss cannot with exercise. And that's where we need to hang our hat. And that's why we are important to this discussion. And that's why we need to be partners in the discussion, not opposed to that. And, you know, in our weight loss studies, this is our recent study we published in 2002, diet versus diet plus physical activity, the weight loss was all the same. But when this study focused on cardiac MRI, left ventricular size, and what we found was with weight loss, diet alone, there was a reduction in the size of the left ventricle. With diet and exercise, we retained the size of the left ventricle. And we probably remodeled the left ventricle to make it healthier. We made the ventricle not just have less load on it, but to be healthier. We changed the physiology. We also did a small study before that leading up to it, where we looked at resistance training and cardio, and we saw the same effect, or cardio. So there's benefits to this that I think are critically important. The one study that's out there in the literature that has looked at weight loss with these medications with exercise added has actually done a weird thing. It's actually gotten people to lose weight initially over 8 weeks with basically a very low calorie diet. And after they lost significant weight, then they added liraglutide at that time. And liraglutide was added, placebo was added, or the combination of a liraglutide or placebo with exercise was added. And you can see the weight change that was occurring, that the exercise combined with liraglutide seemed to do better than all the other ones combined, right? And it's not a lot more weight loss, but it's 6 kilograms more weight loss, even after. So it's an additive effect that we were able to get there. And I think the more important factor here is that the only folks who saw improvements in fitness were the people who exercised. Fitness did not improve in people who were not exercising even though they were losing weight. That's important, and it's critical. So let me end here with a few slides, and we can open it up for questions in a couple of minutes, but this is critical. I also feel that there's a space for exercise physiologists and exercise scientists that is different than the space for physical therapists and occupational therapists. It's not one against the other. But for individuals who go through an obesity treatment program, who are identified by their physician or healthcare provider that have physical mobility types of limitations, don't push them to an exercise physiologist. Get them over to physical therapy to get that rehab part going, to kind of give them the functional ability to then be transitioned over to a more traditional exercise program. But for those individuals who don't have these mobility kind of limitations, let's get them over to the exercise professional to save the more expensive resources of physical and occupational therapists for those who really need it. So let's differentiate where we're directing people just like we would in medical care. That's again where our space is, right? We got to find our space and identify it and make it be known that that's what we do. So I'll end with these last couple of slides. In this age of anti-obesity medications, which is not going away, we need to recommend exercise, but not for weight loss. That's not our angle. We need to collectively think about the holistic patient. And weight loss is just one component of that. But physical activity is another factor that gives us something different than what weight loss does. And we need to be thinking about it from that particular angle. The other thing that we need to think about is, how do our patients feel about activity and what are they doing? We've been surveying patients in our clinic, and I'll do this quickly, who are on these anti-obesity medications. And what we're finding is that the vast majority of them are not exercising or exercising enough. Most of them are not meeting the guidelines. Most of them are not exercising most of the week, and not many at all are doing resistance exercise when prescribed these medications. So while we think it's helpful, it might be, they're not getting the guidance they need, another place for us. And why aren't they? This is what they're telling us. These are just some of the things they say to us. They're uncomfortable. They don't like the way they look. They feel that they're being judged. They feel that people are saying they're taking the easy way out. We need to create an environment of exercise and physical activity that makes and helps people who are on these medications feel comfortable in this aspect of what we're doing and what they need to do and what we hope they do. So we need to change our philosophy. So what do we need to do? We need systems and approaches to be in place that are going to be supportive of these holistic programs that encourage physical activity. We need healthcare providers to just not tell people to exercise, but we need them to have support systems in place. We need, I don't know why it's going forward, but we'll go back if I can. We need healthcare payers to pay for this. We need people to help pay for this for people who can't. And we need to provide this in an equitable and inclusive manner for people, not just people who can afford to get this support, but people who need it and can't afford it. How do we do that and do it well? And it doesn't mean everybody goes to the gym. That model will not work. And finally, we need our professional organizations, universities and colleges and others to educate students on how we fit into this space and modify their programs. We need pharmaceutical companies to step up and do their part and support this work as well. They have to. I don't know why it's jumping, but we need them to do that. And we have a dietary parallel that has to happen as well. Okay. I'm not quite sure why this next slide changed colors on me, but the point of it is sit less, stand more, move often. We need to do that. And without getting into this, please, please, please stop the infighting on what is the best exercise for people to do. There is not one. The best exercise for people to do are the ones that are going to give them the health benefits. If I only give them cardio training, I'm only going to get cardio benefits. If I only do resistance training, I'm only going to get resistance training. We need all these things, and we shouldn't be infighting about which one's best. That's killing us as a profession. All of them are important. There it is. That's the one I wanted to show you. We need warnings on these things, right? If you're going to sit here more, don't. It's unhealthy for you. That's the warning signs we need. So with that, I will end today. I thank you for your time, and I'm happy to take a few questions with the few minutes we have left. Thank you so much. Any questions or comments? Yeah, here's a microphone, I think. Don't bring in the song now.
Yeah.
Yeah.
So I think one of the primary concerns, and you definitely addressed it, is like sustainability with a lot of these drugs, especially semaglutides. And one of the like most reported side effects is often kind of like one of the mechanisms of action, which is like GI distress, which is what's curbing appetite and causing people to eat less, which can also like, you have a tummy ache, you're not going to want to eat. You're also probably not going to want to be exercising either. So how would you kind of like address that? And what do you think is the best like strategy going forward with that? Because I know like if you start semaglutide, you're often started on a low dose of like 0.5 milligrams and then incrementally increase.
And I'll let the physicians, I mean, she'll be talking this afternoon, I'm sure, about this, and she talk about the titration up and down and so on, and they look at the side effects when they're making these decisions. But you know, the side effect of nausea or GI distress is not the sole reason that people eat less.
No, I understand.
That's just a side effect of this. It's the signaling to the brain and slower motility of the digestive system and so on and so forth. All those. But I think you're bringing up an important point, which we heard in talking to our patients. How do we help them to know how to fit activity in? You know, what we're hearing from patients is it's soon after they take that injection for the day or so that they might feel some of this, and then it kind of subsides before they're. So should they maybe exercise on that day where they're maybe feeling some of this? Or maybe that's an off day. And then when they're feeling not that, then those are the days for activity. So it's about, you know, one size doesn't fit all. And we need to really think about this idea of how do we not just overlay exercise and physical activity on patients with these medications, but how do we overlay it in the appropriate, relevant way for people that are different than what we would do for someone who's not on the medication? That's the different angle we need to be taking. And we would have to adapt. We would do that with any condition. Let's do it with obesity treatment as well. So very good question.
Thank you.
Thanks. Anything else? There's one down front too. So again, I'll let the physicians talk more about this because I'm not allowed to prescribe them, but some of them are approved for adolescents, but not in the lower age ranges of pediatrics. And I think if you saw the Oprah Winfrey special a couple weeks ago, and if you didn't see it, I would recommend you listen. They had a young teenager on there who's on these medications, and how these have been life-changing for some of these folks. So I think that, you know, we need to continue surveillance. We need to keep watching it. But I think there is a place for this, even in younger ages. I'd be careful about the young, but adolescents, they've been shown to be effective and used safely up at least until this point. Yep. Yeah. Hi.
Glucagon receptor influencing thingamabobs are affecting the ability of muscles to hypertrophy?
Yeah, so that's a very interesting question. And I know that there's work going on behind the scenes, but there are some of the, if you think about it, and I kind of hinted at it a little bit, in caloric restriction, you need enough energy to sustain life, but you also need enough energy to build. So there is probably some limitation in what the body's able to build because it's using kind of its energy to just life-sustaining things. So it's not able to so even if you gave them more protein, if you're still in this caloric deficit, it's going to be tough. But there are, for example, other things that are being worked on in the medication where we have dual, triple action, but they're now trying to add on things like myostatin. They're trying to add on other factors that maybe are going to help the body's ability to kind of not break down the muscle or retain it a little bit. Or so I know that those agents are in development and being worked on and showing some promise. But even then, in my opinion, this is just my opinion, and I'll end with this. Even if you retain the muscle, have you improved the quality? And again, my argument is to improve the quality, get up and get moving and do activity, because that gives you your best chance of improving the quality. So I think we still need to move beyond just volume and move towards quality of that tissue to give people the overall best holistic benefit would be my argument. And I think that's where we need to position activity and exercise in this whole thing, along with appropriate nutrition. And last thing I'll say is these medications, what you hear from patients is it's reducing the food noise. I don't have to I'm not thinking about food all the time. And from a nutritional perspective, by not having to focus on calorie restriction, because the meds are doing that, I can now shift my focus, not mine, but dietitian's focus, to quality of the diet and not worry about cutting the diet, right? So it even changes how we can angle this on a nutritional perspective as well, and it gives us a better chance. So I think that there's a good place for these, but we need to keep paying attention. I think we're out of time, am I correct?
So this is, if you haven't caught, this is the first lecture of 2 lectures. So we have a second lecture in the same location at 4 p.m. Today we're going to have Dr. Velasquez give lecture this afternoon. So thank you everybody for attending. But before we end, I do want to give Dr. Jakicic his lecture. So thank you very much.
Great. Thank you so much. It was really a great time. Appreciate it. Thanks. Appreciate it. Thank you all.
4 o'clock back here for our second lecture.